Hi, welcome back to part 2 of electrolyte and acid-base challenging questions and answers. This is more questions, but a similar number of slides, and hopefully get done in a little less time than part 1. No financial disclosures, and just to jump right into it, since we're now used to the format. The first few cases are similar to part 1, and then most of the last questions are much more multiple choice, straightforward questions. So this is an 18-year-old who's brought in with a change in mental status, suspected toxic ingestion. Blood pressure is 1/73, heart rate's 89. She's tachypnic with a respiratory rate of 40, low-grade temperature. She vomited once in the emergency room and is poorly responsive. So here are her initial chemistries: normal sodium, normal potassium, metabolic acidosis, some renal insufficiency, normal or maybe low normal glucose. She is acid test negative, lactates within normal range, serum osmolality is 295, and her blood gas shows a pH of 7.39 with a PCO2 of 25. So what would you recommend for this young person? Would you have them breathe into a bag? Start them on an insulin drip, maybe consider a forced alkaline diuresis, give 5% dextrose, or like the last case, does this person also need famotidine, the alcohol dehydrogenase inhibitor? I'll give you a moment to think about it, then we'll pick the right answer, or I'll show you the right answer, and then we'll discuss the other choices. So this is a different toxic ingestion scenario. And the correct answer here is a forced alkaline diuresis, because this is salicylate intoxication. And there's a few clues to that we'll touch on and account for her interesting acid-base picture. So we talked about this in the overview talk. One of the high anion gap acidosis syndromes that's from salicylate is characterized often by tinnitus, even deafness in extreme. There can be fever, probably due to mitochondrial decoupling, tachycardia, but the hyperventilation is a key component of it, particularly early in salicylate intoxication, where there's primary drive of ventilation. So there's this respiratory alkalosis and metabolic alkalosis and acidosis. So let's come back to her labs, because they're interesting. So remember in the overview talk, I mentioned that when you compensate for an acid-base disturbance, you don't correct to a normal pH. So a pH of 7.39, without seeing anything else, really tells you that there's at least 2 acid-base disturbances here, and maybe more. So let's go through this in our systematic approach. So there is no acidemia or alkalemia, but we know that there's at least 2 processes going on. There's a respiratory alkalosis and a metabolic acidosis, but I don't really know which one is the primary process. However, based on her presentation and the fact that most toxic ingestions do have a metabolic acidosis, that's what it probably is, along with a primary respiratory alkalosis. So how do we prove that there's a primary respiratory alkalosis? We go through our algorithm and look for compensation. And if you use the Winter's formula, you're going to predict a PCO2 of 32, but we measure it at 25. By definition now, we have a primary respiratory alkalosis. Then we'll go to the acidosis and calculate the anion gap. It's elevated at 24. So she has an anion gap acidosis. And now we'll look at her delta-delta, which is the change in anion gap over the change in bicarb. So her change in anion gap is approximately 14. If you take a normal gap of being 10 to 12, then hers is 12 to 14. And then if the acid accumulation or being completely offset by a bicarbonate reduction, this ratio would be 1:1. And it's not. The bicarb is actually higher than one would predict, so that it suggests that there is an underlying metabolic alkalosis. And that's really can only be determined indirectly through this delta-delta, the fact that she had a history of vomiting in the emergency room, and that the bicarb was higher than one would expect for her decrease in bicarb. It was higher than expected and not accounted for or offset by the increase in her anion gap. And again, serum osmolar gap, in this case, you would expect to be 0 or close to it, because aspirin or salicylate is classically not associated with an osmolar gap, but the anion gap acidosis. So we've seen this before, so I won't belabor it. This is a simplified cartoon to show why alkalinization works. So if you increase the pH, you shift the acid into the salicylate minus. So you're basically creating more salicylic acid. And this allows for diffusion then down its concentration gradient outside of the cell. So you shift it out of the brain, and in the urine, you capture more without reabsorbing it, allowing for additional excretion. So alkalinization is the answer for an approach to a patient with salicylate. If you thought this patient was hyperventilating, you could have them breathe into a bag and increase their PCO2, but in her case, that would worsen her acidosis. Insulin drip, obviously, you would use for DKA. Really no role for the dextrose, and this is not an alcohol ingestion, so really no role for flumetazole. Okay, case 11. This is a 35-year-old with HIV and is maintained on heart therapy. Most recent regimen being raltegravir, tenofovir, emtricitabine. Been doing well, but on a routine visit has the following chemistries. Serum potassium is 2.8, so it's low. Bicarb is low at 18, so there's a metabolic acidosis. A bit of renal insufficiency with a creatinine of 1.7. Normal glucose, normal calcium, low phosphate. Urine is looked at, and it shows trace protein, 3+ glucose, no blood, and no leukocyte esterase. So what might be the next step in managing this gentleman? Would you send off his stool for microbiology and maybe do a colonoscopy? Discontinue tenofovir, discontinue raltegravir, send an autoantibody panel, or get an MRI of the adrenal glands. I'll give you a moment to think about these choices, and then we'll discuss the correct answer and the other choices. So this is tenofovir, but what's going on here? Well, let's go back to the case and begin to break it down. Typical outpatient scenario, you won't have an ABG, but this person has a bicarb of 18. So this is most likely a metabolic acidosis. We also know he is hypokalemic, he's hypophosphatemic, and has a few other abnormalities. So as we did in the fundamentals talk, any acidosis, you want to distinguish anion gap versus non-anion gap. And this turns out to be an anion gap of 8, which is normal. So it's a non-gap acidosis. And by way of review, if you break down anions and cations in cells, the negatives and the positives have to add up. Bicarb is the major buffering system. So to become acidotic, you can do that in a couple of ways. You can lose bicarb, which will shrink this space, or you can add acid, which will then be buffered by the bicarb and also shrink this space. So here, the gap remains the same if I take out bicarb or I add an HCl equivalent of acid. So this is a non-anion gap acidosis. The gap, you recall, is comprised of albumin predominantly. And the differential of a non-gap acidosis is bicarb loss through the gut or bicarb loss through the kidney, so-called proximal RTA, but can also be seen with impaired hydrogen ion secretion in the distal RTA or in the type 4 RTA that we talked about in part 1. So back to the case. This urine pH is inappropriately high. We have a non-GAP acidosis. We're thinking about an RTA, either bicarb loss or hydrogen ion retention. So that's the type 1 versus the type 2. But there's a few other clues here. The hypokalemia and the hypophosphatemia really suggest, particularly the hypophosphatemia, really suggest a more proximal tubular issue. And the real clinker, or the real clue here, is glucose in the urine without an elevated blood glucose. And since glucose is absorbed exclusively in the proximal tubule, this tells you that we're dealing with a type 2 or a proximal RTA, also known as a Fanconi syndrome. So the differential diagnosis of RTA, again, hyporenin, hypoalgia, the only one that gives you elevated potassium. And then the urine pH in the proximal is variable because of distal bicarbonate reabsorption. It's typically high in the classic distal. This gentleman's was elevated. And then you have these other clues, such as low serum phosphate, glucose in the urine. The classic distal is associated with nephrocalcinosis. The causes of these, in this case, tenofovir, drugs in this family, you can see it with myeloma. You treat it with bicarbonate, as opposed to the classic distal, which is the hypokalemic version, most commonly seen as an autoantibody in Sjogren's syndrome, can also be seen in lupus, and then we talked about the hyporenin hypoalgia in previous cases. Okay, so as a way of update, tenofovir has recently been replaced with a different salt. Instead of the fumarate salt, it's now alafenamide. And it turns out that alafenamide is effective at much lower doses. So we're seeing and expecting to see less of this proximal RTA. And tenofovir fumarate can also cause chronic kidney disease, and we're hoping that we'll see less of that going forward as well. So coming back to the other choices, diarrhea would lead to a non-GAP acidosis, but usually intact renal acidification. So the urine pH is the clue that it's more of an RTA. This was the correct answer. Maltegravir is not particularly associated with RTAs. This would be to look for Sjogren's or the distal RTAs, and we weren't really worried about hypertension and adrenal glands in this case. Okay, this is a 47-year-old with known peptic ulcer disease and a 3-day history of epigastric pain, profuse vomiting, and an inability to take fluids in. She's in moderate pain, she's hypotensive, she's borderline tachycardia, she's got dry mucous membranes. Sodium is 124, low, potassium is low, chloride's low, bicarb's high. She also has some renal insufficiency, an elevated lactate, and the following blood gas, pH of 7.65 and a PCO2 of 38. So this is a challenging question, and I may bounce back and forth to the choices as we go through it. I'm going to give you a moment to look at these choices, and I'll give you a clue as to how to systematically approach it. But these are similar to real boards questions, and what we're trying to figure out in this patient is metabolic alkalosis and respiratory acidosis, metabolic alkalosis, and the following. And the way to approach this is to go through your systematic approach and look for the disorders in order. And I'm going to go back for a second because we're going to go through this more systematically in a moment. But the overriding feature is this alkalemia and alkalosis. We'll also note her pH. So let's just figure out what she has. The correct answer for those of you that are really good or guessed well would have been D, of the metabolic alkalosis, respiratory alkalosis, and metabolic acidosis. And let me walk you through how we get there. So back to our standard approach. We've got alkalemia and metabolic alkalosis. So now we want to know whether this PCO2 is appropriate for compensation. We know we have this alkalosis. And how do you get alkalotic? You either eat alkali or you lose acid. And if you eat alkali or lose acid, it's usually renal or GI. And this is the differential that we had discussed earlier. And then hypokalemia. But back to the case. So this is one of the rules of compensation that I usually have to look up. But the rule says that the increase in PCO2, the expected increase, would be 0.6 to 0.7 for every milliequivalent change in the bicarb. So the bicarb is 40, so the change is 16. So 16 times 0.6 would be 9.6, so say around 10. So the predicted PCO2 should have been around 50, and we're seeing it at 38. So we now know that there is a primary respiratory alkalosis. So I won't do it for the sake of time, but if you go back to your choices, you've now eliminated at least a couple of those choices, because we're looking for an answer that has metabolic alkalosis and respiratory alkalosis. And the question is there yet another acid-base disturbance? And we know there is, because all those choices had 3 choices. So we come back to looking at our anion gap, and it turns out it's quite elevated at 19. So we have the correct answer. We're actually given the answer in the form of an elevated lactate. So this is an anion gap acidosis superimposed on the metabolic alkalosis and respiratory alkalosis. So when you come back to your choices, this was the right answer. Metabolic alkalosis was common to all of them. Respiratory alkalosis, once you figured that out, excluded those 2 choices. And then it was just figuring out the superimposed anion gap acidosis, which was hinted at by the lactate. Okay, now we shift for the final series of questions to a different format. These will go more quickly because it's going to be the same treatment choices, A through E, with a different clinical vignette to introduce the question. So let's start with a 22-year-old with no past medical history. He's confused. Serum sodium is 106. Serum osmolality is 240. Urine sodium is 45. And his urine osmolality is 40. So which of these would be the best treatment option for this clinical scenario? Give him normal saline, give him hypertonic saline, free water restrict him, give him hydrocortisone, or just leave him alone. I'll give you a moment to think about that, and then we'll go through the case and the approach. So what is this? This, obviously to me, it's straightforward. To those in the audience, you might have to think it through. But this is water intoxication. And the clue, as I'll show you, is in this very low urine osmolality. So you'd seen this before in previous cases and in the overview talks. So we have what's essentially confirmed. We know it's hypoosmolar hyponatremia. He's euvolemic, and that urine osmolality of 40 tells you he's drinking a lot. So this is psychogenic polydipsia. Okay, same treatment choices, but a different clinical scenario. This is a 52-year-old female with COPD, worsening dyspnea, and she presents with a seizure. On exam, she's confused, stable vital signs, moist membranes, no edema, so euvolemic. Sodium is 110, osmolality is 251. So hypoosmolar hyponatremia. Urine sodium is 150, urine osm is a 710. What do we want to do for her? Normal saline, 3% saline, free water restrict, hydrocortisone, or no treatment? I'll give you a moment to think about that. And the correct answer in this case, in a patient with symptomatic hyponatremia who's seizing, you have to get that sodium up by at least a few milliequivalents in order to get them out of seizure range. And this, of course, is likely a case of SIADH in a person with pulmonary disease. And you're not going to be able to correct that sodium with normal saline. You need to get something higher than her urine osmolality. And again, that's the key to the case at 710. So same algorithmic approach, but in this case, a euvolemic patient with a very high urine osmolality of 700 when the serum sodium is 110. So this is SIADH. So how do we treat this? Well, in the emergency room, and even in the field, for example, at the Boston Marathon and other places where this can present, you can safely give 100 mils of 3% saline to any patient and not worry about overcorrecting. It's going to typically correct the sodium 2 to 3 milliequivalents. You can repeat it at least one more time, sometimes 2 more times, to get someone out of the severely asymptomatic range. If you know that the hypernatremia is acute, then you don't have to worry so much about the rate of correction, but we rarely know that. And of course, this would be SIADH. We would be looking at less than 0.5 milliequivalents per hour, not to exceed 8 to 10 in a day, and really 6 to 8 milliequivalents in a person who would be at increased risk for CPM, or central pontine myelinolysis. Those risk factors would be alcoholics, malnutrition, liver disease patients. So better to go slow in terms of 24-hour goal, but important to get out of the severely symptomatic range. Okay, different case. 67-year-old with fatigue and low back pain. Serum sodium is 124, glucose is 76, total protein's 13, albumin's 3.6, hemoglobin's 9. What's the best treatment option for this patient? Normal saline, 3% saline, water restrict, hydrocortisone, or no treatment. I'll let you guys vote. And this is a trick question that every year a significant fraction will get wrong because we break from following our algorithm. And this is a case of pseudo-hyponatremia. Notice you were not given a serum osmolality. The clues are that this is multiple myeloma with the anemia and the very high total protein level. And this is someone who you should not give normal saline to, fluid restrict, or otherwise. So don't get fooled in real life, and certainly on an exam question about treating a pseudo-hyponatremic patient. And this occurs due to an artifact of the way sodium is measured in serum. And I'll leave it at that for now. But any space-occupying substance in the serum will falsely lower the measured serum sodium. And as mentioned, you do the osmolality, or if you are able to, measure it on whole blood. Okay, same treatment choices, different scenario. 45-year-old with diabetes, hypertension, and ischemic cardiomyopathy on aspirin, carvedilol, captopril, glipizide, and furosemide. An exam, the blood pressure is 135 over 94, heart rate's 80, membranes are moist. JVP is elevated to the angle of the jaw, there's edema. Serum sodium is 123, urine sodium is 10, and urine osmolality is 570. So what do we want to do for this person? Do we want to give him, again, same choices, saline, 3% saline, water restrict, or hydrocortisone? And hopefully, most of us would realize that this is heart failure associated hyponatremia. We certainly don't want to give more salt. We want to give diuretics. We also want to water restrict, as is classically done with these heart failure patients. So this patient falls into this part of our diagnosis algorithm. Okay, just to make note, we're switching gears now. Same format, but a different set of answers. And these next questions are focused on potassium. So this is a 47-year-old man with type 2 diabetes, hypertension, heart failure, nephrotic range proteinuria, peripheral edema, some renal insufficiency with a creatinine of 1.6, potassium in just slightly above normal range. Most labs, in our lab, it's up to 5.3. It varies from lab to lab, so slight elevation. And that happened since he started on captopril, despite adhering to a potassium-restricted diet. So we're taking dietary intake off the table. We're dealing with mild to moderate hyperkalemia. So what would be the best treatment option for this gentleman? A thiazide diuretic, B, hydrocortisone, C, insulin, D, hemodialysis, or E, sodium polystyrene sulfonate, also known as Cansolate. So I'll give you a moment to think about those choices since it's the first time you're seeing them. This is a very common clinical scenario. I would argue that many of us would just accept the potassium in this range, but here's someone who would benefit from this treatment choice, which would be to use a diuretic, which is one of the tools in the toolbox for helping treat the hyperkalemia associated with renin-angiotensin inhibitors, as well as the type 4 RTA that some of these folks have. And just by way of review, sodium absorption mostly occurs in the proximal tubule. These are weak diuretics because of the distal compensation and reabsorption of sodium, but osmotic diuretics such as mannitol or carbonic anhydrase inhibitors. These are the loop diuretics. We've talked about them, furosemide, the site of Bartter syndrome. Thiazide diuretics, where 5 to 10% of sodium is reabsorbed, 20 to 30% here. And the final potassium and sodium reabsorption occurs in the collecting duct. The reason you get hypokalemia and metabolic alkalosis when you block this absorption is you interfere here with loop diuretics, here with thiazide diuretics. When you do that, there's more distal delivery of sodium, which gets reabsorbed in the collecting duct, and in exchange, hydrogen and potassium are secreted. If you lose hydrogen ion, you get alkalotic. You lose potassium, you become hypokalemic. Okay, same treatment choices, but a different clinical scenario. This is an 88-year-old woman who had a partial sigmoid colectomy for perforated diverticular abscess and septicemia 2 days ago, and she's been anuric since the operation. Her potassium is 6.5, but at least as of now, there are no EKG changes. So would you give her thiazide, give her hydrocortisone, give her insulin, give her hemodialysis, or give her KX-Lite? I'll give you a moment to think about those choices. It's usually between two here, but really only one correct answer, and that's hemodialysis. This patient's been anuric. This is a dangerous potassium in the setting of no urine output, and even though there's no EKG changes, that can change rapidly. The reason you wouldn't want to use sodium polystyrene is that she's had bowel surgery. None of the newer resins for oral potassium binding are approved in this setting or would be effective, and really hemodialysis is really your only choice. Just by way of review, to get hyperkalemic, decreased urinary excretion, she has essentially severe acute renal failure. And then you have the inhibition of that cortical collecting duct potassium excretion mechanism, which is predominantly aldosterone driven. So any med or family of meds that block the renin-angiotensin system, including NSAIDs, obviously ACE and ARBs, spironolactone, direct blockers. Heparin blocks aldosterone biosynthesis, as does cyclosporin. And then there are certain drugs that you may find people on that block that sodium channel in the collecting duct, one of which is the target of amiloride, a case-bearing diuretic. But it's also the mechanism of hyperkalemia in Bactrim-associated hyperkalemia due to the trimethoprim component, which acts like amiloride. So by way of very high-level quick review, when you have a severe hyperkalemic patient, you're going to stabilize the cardiac membrane by giving calcium chloride or gluconate. You're going to shift K into cells by giving glucose and insulin, giving beta-adrenergic agonists, either inhaled or otherwise. Sodium bicarbonate actually doesn't work so well in patients on dialysis. And then, of course, you want to remove that excess potassium. And if you can't do it through the endogenous renal function and it's not safe to bind it in the gut, you're left with dialysis. Okay, case 19. Same treatment choices. An 18-year-old with no prior history who presents with polyuria polydipsia. Sodium is mildly low, potassium mildly elevated, metabolic acidosis, mild renal insufficiency, elevated glucose. What would be the best treatment option for this serum potassium? All right, well, I think most people probably recognize this as new onset diabetes with polyuria polydipsia, elevated glucose. It's an osmotic diuresis, leads to volume depletion, and the insulin resistance leads to hyperkalemia. So you would give insulin, of course. And this falls into the category of cellular shift, where metabolic acidosis and the elevated blood sugar are responsible for the shift of potassium out of cells. Remember, we talked about in the overview talks that the concentration of potassium in the cells is opposite of what it is in the serum. It's really, really high. It's 140 milliequivalents of potassium in the cells, opposite of sodium. And that's why it doesn't take much shift to cause hyperkalemia. Okay, same treatment choices, yet another scenario. So this is a 26-year-old with acquired immunodeficiency syndrome, fatigue, weight loss, fever, orthostatic hypertension, hyponatremia, and hyperkalemia. We're given a quart stim test with a baseline of 7, but 30 and 60 minutes after the cosintropin, her cortisol levels only go to 10 and 11. So what's the correct choice here? This probably takes no thinking based on the clinical scenario and those treatment choices. So we'll just jump right to it. Hydrocortisone, of course, as this is adrenal insufficiency or Addison's disease again. So you've seen that a couple of times in the cases. Rarely is the presentation so clear-cut as they are in these clinical vignettes. They're usually contradictory or conflicting data, so it often requires more of an evaluation. But for the purposes of thinking about the physiology, these cases are instructive. Okay, we're on the home stretch. This is case 21, and it's now yet another different set of treatment choices for these final few cases. So for these cases of hypokalemic metabolic alkalosis, so we've talked about that a few times today, all of these are going to be hypokalemic metabolic alkalosis with the following treatment choices. So for this one, a 16-year-old with amenorrhea, body mass index of 13, so quite low, and a urine chloride concentration of 5. Is this most likely diuretic use or surreptitious vomiting? Is she hypokalemic periodic paralysis? Is this Gittleman syndrome, which we've had a case of already, or Conn syndrome, which is hyperaldosteronism? So I'll give you a moment to think about those because it's the first time you're seeing these choices. So hypokalemic metabolic alkalosis with this brief history, but a very low urine chloride concentration. All right, so hopefully most people recognize this as surreptitious vomiting. I suspect that some may have thought of diuretic use, but again, the urine chloride there would be high, not low. The same with the Gittlemans. Remember, Gittlemans and diuretics kind of look like each other. And of course, this patient's not hypertensive, or at least we're not told so. So it would be weird to think of Conn syndrome in this setting. And in that setting of hyperaldo, the urine chloride is elevated. So you've seen this slide before, and in this case of this young lady with a very low urine chloride, you really don't have to go any further once you've excluded hypertension. The only thing on the list is surreptitious vomiting, and not an uncommon presentation for a young teenager with an underlying eating disorder. Okay, same choices, different scenario. Again, hypokalemic metabolic alkalosis, but this time it's a 35-year-old with new onset of hypertension. So what's the most likely cause? Diuretic use? Doesn't seem to make a lot of sense. Surreptitious vomiting, hypokalemic periodic paralysis, Gittleman's or Conn syndrome, or also known as hyperaldo. I hope this is close to 100% correct response rate from the audience, because the only one on here that causes hypertension is the Conn syndrome. So that's pretty easy. You don't even have to worry about urine chloride or other things. So again, the differential for cryptogenic or unexplained hypokalemia and hypertension comes to renal artery stenosis, Cushing's, Little's, or in this case, primary hyperaldo. So I put this slide up not because I expect you to remember it, but just as a way to remind you of all the drugs that we use that interfere with the renin-angiotensin-aldosterone system. So this would be in the cortical collecting duct, so that final part of the renal tubule where potassium and sodium are regulated. And this is the principal cell. This is the epithelial responsive sodium channel called ENaC. This is the one that's blocked by amiloride. It's also where the mutation for Little syndrome is. And it's the absorption of sodium here without chloride that generates this lumen negative potential, which allows for hydrogen ion secretion and potassium secretion. This, of course, is regulated by aldosterone, which circulates, binds to its receptor, and then stimulates the number of these channels as well as their open probability, which allows then for sodium absorption and potassium excretion. So in primary hyperaldo, this is kind of an overdrive, and you're going to get sodium absorption with volume expansion, hypokalemia, hypertension. Digoxin, we still use that drug, interferes with the sodium potassium ATPase. And I mentioned amiloride here, trimethoprim from Bactrim, and of course the other drugs that interfere with aldobiosynthesis and the upstream molecules or signals such as the renin-angiotensin system. Okay, we're on the home stretch, the final few cases. Same choices. Again, hypokalemic metabolic alkalosis. This is a 32-year-old woman with a history of bulimia, so we're given that. Random urine chloride concentrations on 3 separate clinic visits were 40, 67, and 26. So she's got hypokalemia, metabolic alkalosis, and those urine chlorides. Is this most likely diuretics, surreptitious vomiting, hypokalemic paralysis, Gittleman's, or Kahn syndrome? I think by now folks are probably getting the hang of it, and that elevated urine chloride, we're going to come back to that same slide, can only be explained really by diuretics. So I kind of jumped the gun with the highlight, but unless you suspect a hereditary disorder, the 2 conditions that are going to give you a lot of chloride in the urine in a normotensive patient, so we're excluding this one, would be diuretics or Barter's-Gittleman's. This one's made a bit easier by her history, and at least not told of a family history. If you really can't tell, then you can do a diuretic screen, as came up on one of the previous cases. So second to last case, again, same scenario, hypokalemic metabolic alkalosis, same choices. This time it's a 15-year-old girl with recurrent episodes of muscle weakness since childhood, a urine chloride concentration that's 65 milliequivalents per liter, and a 24-hour urine K that's 60. So if you may or may not recall, but in the presence of hypokalemia, this would be a high urine potassium. So with that clue and the fact that her brother has similar symptoms, which of these is most likely? I'll give you a moment to think about it. But there's only 2 genetic conditions up here, hypokalemic periodic paralysis and Gittleman's. The difference is, in Gittleman's, as you've already seen, is that you expect high urine potassium and chloride, whereas hypokalemic periodic paralysis is a shift between cells. So the urine levels there are normal or not elevated. So that's what tells you this is Gittleman's. You've seen this slide before, renal K wasting with normal or low blood pressure, Barter, Gittleman's, or diuretics, but we excluded that here because we know of the hereditary disease. And this is kind of for bonus points. How does one distinguish Barter's and Gittleman's? And that has to do with the urine calcium. It has to do with the way that different transporters reabsorb calcium, but turns out to be a very useful clue clinically. Because you may recall that we use thiazides to treat calcium-based kidney stones. And that, of course, is because it's reabsorbing the calcium out of the urine. So a very low urine calcium would be seen with Gittleman's and the opposite, or a normal urine calcium with Barter's. Okay, I think this is the last case. Same treatment choices. This time it's a 20-year-old with thyrotoxicosis, recurrent episodes of muscle weakness. Well, at this point, we've gotten all the answers selected except for one, and this is indeed a case of hypokalemic periodic paralysis. And the classic findings are actually folks of Asian descent, often with a history of thyroid disease. The adrenergic stimulation and insulin stimulation will often unmask the hypokalemia. And then just by way of review, typically seen, as I mentioned, in Asians, folks with Asian descent, typically males, precipitated by meal or exercise. And the urine potassium, if you're able to measure it, would be low because there's no renal defect here. It's I think a calcium channel that interferes with potassium shifting between cells. So with that, I'll leave you with some suggested reading. Thank you for your attention, and I hope these cases were instructive. Thank you.